This is Lesson 5, Part 3, Obstetric Procedures. The first obstetric procedure we will discuss is version. There are two types of version. The first is external cephalic version. This is used as an attempt to turn the fetus from a breech or shoulder presentation to a vertex presentation. It may be attempted after 37 weeks gestation. Before external version is attempted, ultrasound is completed to determine the fetal position, locate the umbilical cord, rule out placenta previa, evaluate the adequacy of maternal pelvis, and assess the amount of fluid, the gestational age, and the presence of any anomalies. During the version procedure, the nurse should continuously monitor the fetal heart rate and pattern for bradycardia and variable decelerations. The mother's vital signs and uterine activity should be monitored. The nurse should also assess for vaginal bleeding. Internal version is accomplished when the physician inserts a hand into the uterus and changes the presentation to cephalic from podalic or foot presentation. Induction of labor is a chemical or mechanical initiation of uterine contractions prior to the onset of spontaneous labor. Labor may be induced electively for indicated reasons or for indicated reasons. An elective induction is started without a medical indication for induction. The indications and contraindications for induction of labor are found in box 17-8 in your textbook. A Bishop score can be used to evaluate inducibility. A score of 8 or more on this 13-point scale indicates the cervix is soft, anterior and 50% or more effaced and dilated 2 centimeters or more. The American Academy of Obstetricians and Gynecologists and the American Academy of Pediatrics do not recommend elective inductions until the pregnancy has reached 39 weeks gestation or greater. Cervical ripening methods. You need to review the medication guide on page 462 and 463 in your textbook. Cervical ripening is accomplished by chemical agents or mechanical and physical methods. Chemical agents used are preparations of prostaglandin E1 and prostaglandin E2. These have shown effectiveness to ripen the cervix prior to the onset of labor. The advantages include initiating labor, eliminating the need for oxytocin, and a decrease in the amount of oxytocin required in the induction. Disadvantages include PGE1, while less expensive than PGE2, is associated with a higher risk for uterine tachysystole with abnormal fetal heart rate pattern and meconium amniotic fluid. As of 2009, PGE2, the vaginal insert, dinoprostone, has not been approved by the FDA for induction. It does have the advantage of easy removal if adverse reactions occur. Mechanical and physical methods include mechanical dilators that ripen the cervix by stimulating the release of endogenous prostaglandins, balloon catheters, Foley inserted into the intracervical canal, hydroscopic dilators such as laminaria, which is a seaweed substance, absorb the fluid from surrounding tissues and expand, and amniotic membrane stripping or sweeping is a method of inducing labor through the release of prostaglandins and oxytocin. This involves the separation of the membrane from the wall of the cervix and the lower uterine segment. This procedure is uncomfortable and increases the risk of infection. Alternative methods include the use of blue cohosh and castor oil for their stimulating effects, and black cohosh and evening primrose oil to ripen the cervix. While natural, these substances potentiate the effects of pharmacologic methods of cervical ripening and stimulate uterine contractions and could therefore lead to the potential for tachysystole and precipitous labor and birth. Amniotomy can be used to induce labor when the condition of the cervix is favorable or to augment labor if progress begins to slow. This method has been shown to decrease the length of labor by 2 hours even without oxytocin. However, if labor is not induced, the resulting prolonged rupture of membranes can increase the risk of infection. Box 17-9 in your book discusses the procedure for assisting with amniotomy. When documenting amniotomy, the nurse should note the color, odor, and consistency of the fluid and the time of the rupture. Oxytocin. This is a hormone produced by the posterior pituitary gland. Oxytocin stimulates uterine contractions and aids in milk letdown. Synthetic oxytocin may be used either to induce or augment labor. Because of the potential for causing harm when used inappropriately, oxytocin was made a high alert drug by the Institute for Safe Medication Practice in 2007. There are risks to the mother and the baby with oxytocin use. Maternal risks include placental abruption, uterine rupture, unnecessary cesarean birth, postpartum hemorrhage, and infection. Fetal risks include hypoxemia and acidemia, which is caused by the decreased placental perfusion, which is a result of prolonged or too frequent contractions. The protocol for administering oxytocin as well as a drug guide can be found on 465 in your textbook. You will need to review this. Nursing considerations when administering oxytocin include having an evidence-based protocol for the preparation and administration of the drug. This includes having a standard concentration and a standard definition of uterine tachysystole. In 2008, several different groups came together in a workshop to review recommendations for fetal monitoring. This group developed a definition of uterine tachysystole. This definition was that more than 5 contractions in 10 minutes, averaged over a 30-minute window, constituted tachysystole. Augmentation of labor is the process of stimulating uterine contractions after labor has started spontaneously but is not progressing. It is also implemented for the management of hypotonic uterine dysfunction. The two most common methods of augmentation are amniotomy and oxytocin infusion. Some physicians advocate active management of labor, in which oxytocin is used aggressively to promote delivery within 12 hours of admission to the labor unit. The components of active management of labor include early intervention if the nulliparous woman is not progressing at least 1 centimeter per hour, strict criteria to diagnose that the woman is in active labor with 100% effacement, amniotomy in 1 hour of admission to the if spontaneous rupture of membrane has not occurred, one-on-one nursing care with a continuous presence of the RN. While the original procedure for active management of labor were written for the nulliparous woman, active management of labor has been used by some providers on women who are not appropriate candidates. Forceps-assisted birth. A birth that is assisted with an instrument with 2 curved blades. Maternal indications for a forceps-assisted birth include prolonged second stage of labor and the need to shorten the second stage of labor for maternal reasons, either maternal exhaustion or maternal cardiomyopathy and cerebral vascular disease. Fetal indications include an abnormal fetal heart rate tracing or certain abnormal presentation, arrest of rotation, and delivery of the head in a breech presentation. Certain conditions should be met before attempting a forceps-assisted birth. A fully dilated cervix, empty bladder, presenting part must be engaged, membranes should be ruptured, maternal pelvis size should be assessed. Potential injuries to the mother include cervical lacerations, urinary retention, and hematoma formation. Potential injuries to the infant include bruising or abrasions at the site of blade application, facial palsy from the pressure of the blade on the facial nerve, and subdural hematoma. In this slide, you see the different types of forceps you can use in a vaginal delivery. In this one, you see the actual application of the forceps to the fetal head to assist in the delivery. Vacuum-assisted birth. This method of birth involves attaching a vacuum cup to the fetal head using negative pressure to assist in the birth of the head. There are conditions that need to be met prior to attaching the vacuum. You must have a fully dilated cervix, the head must be completely engaged, it must be vertex presentation, the membranes must be ruptured, and you must have no suspicion of cephalopelvic disproportion. Risk to the newborn includes cephalohematoma, scalp lacerations, and subdural hematoma. The newborn may have a higher risk for hyperbilirubinemia and neonatal jaundice as bruising is resolved. Parents may need reassurance that the caput will disappear in 3 to 5 days. This shows the application of the vacuum and the caput that it results.